This is Tammy with NurseMinder, and we are taking on the Glasgow Coma scale today, demystifying it and helping clear up some of the confusion between a few of the different scorings that you can give to your patient. Now, the Glasgow Coma scale is a simple tool. It's objective and it's readily accessible to anybody who works at the bedside. And what's important about this is it helps us to determine the level of consciousness or unconsciousness in our patients. Typically, we use this for anybody where we're concerned about brain injury, brain trauma. And the one-time assessment does give us valuable data, and its use over time helps us to show where things might be moving toward. Now, this scale was first introduced in 1974 by two neurosurgery professors, Graham Teasdale and Brian Jennett. Now, while the Glasgow Coma scale gives us a summary and an overview of our patient's status, it's the trends that we're also using with this tool to identify if our patient is improving, staying the same, or demonstrating worsening conditions. Now, the information gathered from a Glasgow Coma scale, along with the other data that your healthcare provider is taking in, will help them to make decisions. And this can be anything from sending you home on observations with somebody with you, and including diagnostic imaging, testing, and surgery. So we're going to look at eye opening first, and this is strictly only looking at the eyes and the response to the stimulus in the room. What happens when you walk into the room? Does your patient open their eyes? Do they not open their eyes? And if they don't open their eyes, what does it take to get them to open their eyes? That's the essence of identifying the best eye opening. So you walk in the room, they open their eyes, they engage with you, automatically it's a 4 out of 4. Spontaneous. You didn't have to ask them to open their eyes, they're just doing it on their own. A 3 out of 4 is when they open their eyes to speech. Mrs. Johnson, open your eyes. And they open their eyes. Mrs. Johnson, they hear you wrestling, they open their eyes. They might be tracking you, they might not be, but the thing is that when you speak, the eye response is there. That would be a 3 out of 4. Eye opening to pain, it'd be a 2 out of 4. And what that looks like is you walk in the room, you've called their name, you've tried engaging with them, they're not responding spontaneously to your presence, they're not responding to your voice. And so now we're going to see if we can stimulate them. You might want to do a little pinch. You may want to do a sternal rub if that's what you need to do. And another option is we often will take our pen into the bed here of the nail and press down to see if there's a response, okay? If they open their eyes to the stimulus, that's number 2 out of 4. Opening eyes. The best we get is that they only open their eyes when there's contact with pain. And then if they don't respond to any of that, they get a 1 out of 4. No response to pain, no response to speech, and they're not spontaneously opening their eyes. So that's the eye movement. Now we're going to move into the best motor movement. You'll see that the range expands from 1 to 6. There's a few more options in here. Now, a 6 out of 6, best case scenario is that they can obey commands, meaning, Mrs. Johnson, can you raise your right hand? Understanding, comprehension, and movement. Mrs. Johnson, can you close your eyes? Right, so when they can obey commands, we're going to give them a 6 out of 6. Best motor response, 5 out of 6, is localizing pain. You give them a needle and they go, ow, so they're localizing movement to the pain. If you were to give a sternal rub and they were to bring their hands up to your hand where you are initiating pain, that's localizing pain. That would be a 5 out of 6. Now, a 4 out of 6, what if you are giving the sternal rub? They're opening their eyes, great. So we have a opening eyes to a pain. And at the same time, you notice that they're trying to move away from you. They're trying to push away from it. They're not moving their hand to remove that offending, painful stimulus, but instead they're trying to get away from it. That would be a withdrawal, a 4 out of 6. Now the 2 and the 3 out of 6 speak to abnormal flexion or extension. Abnormal flexion is decorticate. Think core center. So there's an attempt, in my mind, this is how I make sense of it. There's an attempt to like come in and protect, but it's not abnormal. It's not normal. They're not coming directly to the source. Their whole body, so their arms are coming in, their feet are crossing over, and their wrists are in flexion. It's all in here. That would be a 3 out of 6. A 2 out of 6 would be decerebrate, meaning they are moving outward. And so you'll see abnormal extension. Their arms are down and pronated. And then a 1 would be 0 response. So you've asked them to move, you've got pain happening here, and there's no response from any of that. It would be a 1 out of 6. Now the third category is the best verbal response. Now depending on where you work, I have seen patients who are intubated and they're spontaneous in their eye opening, they are aware, they're able to respond to you, and because they're not verbally speaking, people will mark them and downgrade them. So you'll want to check in with your facility to make sure you're practicing with the expected, with the ways in which everybody understands that tool to work for you. I'm going to teach this in how best verbal response is just best interactive response. So we have patients, they can definitely communicate in other ways. So this to me is more communicative than verbal. So how do you measure this? This is a scale of 1 to 5. Best 5 out of 5 is they're orientated. We typically go orientated times name, place, and date. Those are the 3 things we often look at. Do you know your name? Can you tell me your last name? Do you know where you are? And what day is it or what month is it? Sometimes people are in the hospital a long time and they lose track of days. So if you can even pick season, they're able to identify, they look out the window. Oh, it's definitely spring or summer. They're orientated. If somebody is not verbally speaking with you, how do you measure that? Well, if they're deaf, you get an interpreter. You ask them, what is their name? And they can spell it out. I am Tommie, right? And perhaps they're writing it. They're intubated sometimes. They can't actually articulate. So maybe they're going to write their name. Best verbal response. Do they know their name, place, and date, for example? A 4 out of 5 would be confused words, meaning they'll look outside and they go, oh, it's winter. No, wait, that's not winter. That looks like sunshine and blue skies and green trees. It's got to be spring. So confused conversations don't always follow a logical flow. It's different from inappropriate words. So confused might be they're still in the ballpark, but they don't have all the right data. They're saying maybe things that don't make sense. Now, when it comes to confused versus inappropriate, confused is the patients are responding in a coherent way, but there is some confusion or distortion around the facts. Inappropriate would be as you're talking to them about their health journey and they go, hey, did you happen to see that red bicycle? and there's no need for a red bicycle in this conversation. It's just like random things thrown into conversation. So if they are coherent and confused, unclear, that would be, the best rating would be a 4 out of 5. If they're throwing in inappropriate words, so a 3 out of 5. Best verbal response, incomprehensible sounds. There's really an attempt maybe to speak, but it's just noises. It's not any articulation of words. So that would be a 2 out of 5. And then 1 out of 5 would be no response. There's no articulation, there's no sounds. That's a 1. So that's the Glasgow Coma scale explained. It's a tool that every one of you has access to at the bedside. Whether you're officially documenting this for your patient's care or you have a curiosity, this is a real quick assessment that can give you information over time, in the moment and over time. Now, how can you support me? Simply subscribe and share this content. I am working to get that 100,000 subscribers. I know it's a vanity metric. For me, it's going to put that YouTube plaque on my wall, and I want that, okay? I've been doing this for a long time, and it's so close. So if you're watching this video was made when I'm just over 95,000 subscribers, and I'm just ever so close to getting over that 100,000, which would be amazing. So that's how you can support me as I support you in your journeys. Just hit subscribe, share this with your friends, and get them to subscribe if it's of value. I don't want you to subscribe just for the sake of subscribing because you're going to get notifications. I want this to be valuable content for you as well. So I thank all those 95,000 who've already subscribed and tell me that what I do is supportive and helping them. And I'm just looking to get over that next hurdle. So if you can help me, that'd be great.